as I missed it. Okay. So we would like to start with our first presenter. Just give me a second. So if you have any question, just share it in the chat. I'll be sharing. Just give me a second. I am having some technical issues. I apologize for that. I hope you can see my screen.
Yes, we can see it.
Oh, okay, just 1 second. I will just. So my first presenter is Dr. Maha. So Dr. Maha Asif, she's an emergency medicine physician working at the emergency department of Medical City of Military and Security Service. Welcome, Dr. Maha.
Thank you so much.
Dr. Afra, maybe you can put the presentation in a presentation mode, please.
Thank you. 1 second. Just 1 second. Oh, okay. Can you see now my slide?
Yes, it is visible.
Okay, excellent. So we are ready, Dr. Maha. You can start.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. First of all, I want to thank Dr. Afra al-Suwaidi for accepting our case for presenting in this prestigious organization. And I want to thank my dear consultant, Dr. Suad al-Suleimani, for all the guidance and support. And I will start with my presentation now. So 2 patients, same crash and same symptoms. A diagnostic clue which should not be, could we go a bit slow? A diagnostic clue which should not be missed. So the presenting complaints of, yes, okay. All right. So the presenting complaints of my patients are as follows. A 43-year-old male and his wife, 40-year-old also. They don't have any past medical history or drug allergy. They are brought by EMS to the emergency department after a motor vehicle collision. They both are having almost similar complaints of headache, dizziness, and shortness of breath. History of presenting illness. They are recently involved in the morning time in a motor vehicle collision. And the mechanism of the accident was that it is a low-speed rear-end collision with no significant vehicle damage. The occupants of the car were the husband and wife themselves. The husband was driving and the wife was in the front seat. 1 day prior, the patient and his wife were involved in a low-speed rear-end motor vehicle collision also. At this time also the mechanism is same. It is struck from behind with minimal vehicle damage. Post-collision, they both have symptoms of dizziness, headache, nausea. They did not seek any medical attention and went home. The following morning, the patient is noted partial symptoms improvement after going in fresh air, but persistent difficult concentration and slow task performance. Later, he with his wife was involved in another MVC on the same day and brought to ED. From here onwards, I'll be discussing the situation of the patient. The wife also reviewed in A&E, and her course of presentation and management was the same. So for the sake of time, we will be discussing one patient today. Presenting complaints of this patient on arrival, he has generalized headache. There is shortness of breath, he's feeling dizzy, and he's having generalized fatigue and body aches. There is no history of direct head, chest, abdominal injury. There is no injury to the limbs also. There is no history of loss of consciousness, seizures, no chest pain or palpitations, no history of any bleeding, any gross hematuria or altered bowel also. On examination, the general examination for the patient is that he is alert and oriented. He is not distressed. His Glasgow Coma scale is 15/15. We did trauma assessment for him. The primary and secondary surveys were unremarkable. The systemic review was clear. His chest normal, bilateral equal breathing sounds. Heart sounds were normal. Abdomen was soft and non-tender. There were no ecchymosis over the abdomen. Neurologically, pupils equal and reactive. Bilaterally, and there is no other neurological focal deficit. Overall, head-to-toe examination was unremarkable. The vitals, yes, I should mention in the start, as you might have noticed, the saturation, he's maintaining is 97% in room air. Heart rate was 79, blood pressure 145/89, temperature 36.5. So we started investigating the patients. Basic labs were sent, X-ray was done, ECG and TROP-T was done. Basic labs were resulted normal. Chest X-ray was normal also. ECG along with TROP-T was normal. We kept him on monitoring. We started with analgesia. With high flow oxygen, 15 liters by non-rebreather mask. We did another investigation. And what do you think it could be? Any guess?
So maybe, Dr. Maha, you can just summarize the case.
Okay. Okay. So all right, we will continue with the management.
No, I mean just summarize the case. So we can just we can pause for like a brief, differential diagnosis and, what do you think this could be? Can you summarize the case for us?
Right. We can start from the beginning.
No, just summarize.
Right. The short summary from the start. We have a middle-aged couple. They both have motor vehicle collision 1 day ahead of presentation in ED. They are symptomatic. They're having headache, dizziness, shortness of breath. They did not review in this day, in the first day of accident. The next day, they continue to be symptomatic and they have another collision, motor vehicle collision. Later, they reviewed in A&E. So we examined, we have continued with the details of the husband. We have examined the patient. The systemic examination is clear. Vitally, he's stable. Basic labs we have done. Chest X-ray, ECG, TROP-T, all is normal. We want to do another investigation to make a diagnosis.
Okay. So just, to open the discussion for our attendees or for our participant. So there's like here a question about head CT scan. So was head CT scan done, Doctora?
The head CT, as there is no direct head injury or loss of consciousness. And also on examination, there are no signs of basal skull fracture. He doesn't have any raccoon eyes or TMJ tenderness or any tenderness all over the head. So we did not go ahead for the CT at that time.
For me, I would think that CT scan is very important in this case because if patient is coming with vague symptoms, let's say like headache, and he had 2 MVA like in a row, I would think about CT scan just to exclude anything that could be missed, because sometimes like a small intracranial bleed can be easily missed. And patient not necessarily that will have significant symptoms, but in the same times, I think maybe it was not even done because my understanding of the case that the MVA was a minor MVA, right? It wasn't.
Yes.
Yes, yes. So okay, so both way it could be. Yani doing CT scan, head CT scan wouldn't be over investigating, but not doing it maybe it also is justified to some extent. So we have a nice thought. So people are asking about lactate, VBG, which is good. But let me ask this question. In a minor MVA, how many of you gonna do a VBG for a patient coming with minor, MVA or even blood test, usually? Okay, we have carbon monoxide, we have tox screen. Okay, everybody is like concentrated to the tox investigation because it is a toxicology webinar. CT scan is a must. I also like I would say yes, it should be like done. We do it. Oh, good. So we have people they do VBG for MVA and ultrasound. So what was ultrasound done, Doctora? Like I mean, just fast exam?
The fast exam was done, it was negative.
Oh, okay, good. So fast is
Uh,
negative.
yeah.
Okay, excellent. So, I mean, we can proceed now and then we can open the discussion for Dr. Suad and also Dr. Sami. I think she's joining us. So you can go ahead, Doctora.
I have a slide of VBG over here.
Oh, okay.
Yeah. So VBG was done, keeping in view that he is having a motor vehicle collision and they were inside the car for a while. And shortness of breath is there. VBG reported as pH is 7.38, PCO2 44, carboxyhemoglobin is 26, bicarbonates 24, lactate 1.2. So we
Okay.
move to our next slide, which is differential diagnosis.
Dora, just focus on the slides here. We can just follow on this one. We can
Okay.
go ahead, yes.
Can we go back? We missed one. The differential diagnosis. After considering the differential diagnosis, we come to the conclusion of CO poisoning because in VBG, carboxyhemoglobin is increased.
Okay.
So the management. Case was discussed with our toxicologist on call, Dr. Suad Soleimani. We started with normal baric oxygen, high flow O2, 50 liter via non-breather mask, and then nasal cannula was used also. Monitoring was done, cardiac monitoring, saturation, blood pressure monitoring, and VBG recheck. Analgesia and fluids were started. Later, the case was discussed for hyperbaric oxygen chamber therapy. Patient was sent for HPOT. After the therapy, patient returned. He was kept under observation for 4 hours. The VBG later was pH 7.35, PCO2 49, carboxyhemoglobin decreased to 1.3%, lactate 1, bicarbonate 21.
Okay, so I'm going to pause you here, Doctora, just to open the discussion for Dr. Suad. So I believe Dr. Suad was the toxicologist who handled this case. And to be honest, I think this case is a very interesting case. It's never straightforward. For me, like, honestly, if I have this patient, seeing this patient in the emergency department, I will be more focused about the MVA. I wouldn't think that, I wouldn't really think about carbon monoxide, although I'm toxicologist. I would be more focused and worried about why this patient keep on having this MVA every time, but when somebody like connect the dot, like he's having MVA or abnormal symptoms whenever he's in the car. So then this, you think, okay, maybe CO toxicity. But honestly, my focus will be mostly on MVA. And I think the physician who saw this patient, I believe it is Dr. Maha, right? I mean, excellent catch, I would say.
Thank you, Dr.
So, Dr. Saad?
Yeah, thank you, Dr. Maha, for presenting. As you said, Dr. Afra, it's always known like CO is a silent killer, and always the presentation is somehow non-specific. So always when we describe CO poisoning, it's sort of non-specific, wide, spectrum of symptoms, of neurological symptoms mainly, and it might be other symptoms as well. So basically, some clinical clues were in this case. First, two patients with the same so clusters of patients. So sometimes in like cases in which there is CO basically from combustion of any or use of the heater at home or anything. If there is any leak of CO at home, then there will be cluster of patients. This is in the car. The thing that basically directed us to think about CO poisoning, that the mechanism did not correlate at all with the clinical symptoms. So basically it was 2 MVC. So sometimes that's why a bit of history might be important. So the initial focus and initial presentation was, as you said, and as if any emergency physician will be directed, is a trauma assessment. And that was the initial focus. So when I came and saw the patient and I asked a bit of history, then did not make sense for me that this mechanism correlate with the mechanism. It did not correlate at all. It was very minor hit. They went out of the car, walking and by themselves. There was no crash to the car or to the vehicle. And then that did not correlate. This is first. Two patients with the same symptoms. This is second. So basically, we thought of, could it believe that this is the second presentation. The first presentation was a day prior to that, and they didn't seek any medical advice for that. They went home and they were having headache, vomiting, and they improved. And later on, they came the second day because he had some cognitive impairment. He could not concentrate, and he hit the front car again. So it was two accidents because of impaired cognitive, impaired cognitive concentration, and he could not concentrate. So basically, those were the clinical clues toward MBC. Thank you.
Excellent. Thank you, Dr. Suad. So, Dr. Suad, what was like the decision made you go for hyperbaric? Because I mean, to be honest, like in my facilities, and I think many other physicians will agree with me, we have very limitation to access hyperbaric. We don't have it in my facilities, and we have to like refer the patient to another facility to do it. And also referring the patient is very challenging. It will take longer process where basically by the time that patient will be referred, almost the CO level will be almost within normal limit. So I just want to know like the decision made you to decide to go for hyperbaric.
Yes. So luckily we are in a military hospital, and we have connections with the hyperbaric, a very good, that belongs to our institute. Totally agree. Hyperbaric is not always like easy, and it's sometimes that might be, the drawback of using hyperbaric oxygen is that it's too far, and then by the time you reach there, it's it's already the CO has been the CO has been eliminated from the body. But basically, what directed us toward insisting on hyperbaric, first, we had the facility within our institute, like, and easily accessed. So directly within like half an hour, like we got a patient to hyperbaric. So early treatment will prevent the delayed neurological sequelae. The second thing, the level. Basically, the level was about above 25. And the patient, this is the second encounter, and initially it seems like he had significant symptoms. The symptoms that they had was severe nausea, vomiting, dizziness, severe neurologic. Yes, it was not an LOC, but it was in somehow severe symptoms. So just having the facility a level above 25, and then the severe neurological symptoms all led to the decision of hyperbaric.
Yes, excellent. I also believe that also like the exposure, I would say it was multiple exposure, not a single one. And I think the other things is that the symptoms were persistent, which actually one of the indication to go for hyperbaric when you have persistent symptoms.
Correct.
Yes.
I agree.
So, Dr. Maha, we can resume the case.
Thank you. Right. So the disposition for this patient was that he remained stable after the hyperbaric therapy and he was discharged home on stable condition. Also, he was advised to review for the second session of HPOT, but he did not report back, unfortunately.
Okay.
Right. The case continues.
Good. Let's go. Yeah.
So we have a second encounter for the same patient. After 10 days, this man, he drives the same car after it is fixed from the garage, and he develops the same symptoms. He has dizziness, shortness of breath, along with chest pain and palpitation also this time. He is investigated. VBG was done. No acidosis, lactate 3.3, carboxyhemoglobin was 1.9 only. His investigations, I have attached in the next slide here, hypophosphatemia of 0.33, which was corrected in A&E. And as the slides show, that it was corrected to normal levels. ECG, there was normal sinus rhythm, but there is T-wave inversion on V3 and V4 only. Both TROP-Ts were negative. So head CT was done this time. There is no diagnostic pathology identified in the head CT.
Oh, okay, excellent.
Third encounter is after 3 days of this re-exposure to the same car. Patient is having continued symptoms, dizziness, headache, palpitations. He's investigated. Basic labs are done, which are normal. ECG and TROP-T both are unremarkable. CT brain was already done previously, which is reported normal. He was this time planned for hyperbaric again because of persistence of symptoms, and he was also referred to cardiology. After hyperbaric session, he reported improvement of symptoms, and he was discharged on stable condition on total resolution of the symptoms.
Excellent. So my understanding, like he went for the second hyperbaric but delayed.
It was delayed as he did not present
He didn't
on his appointment
appointment.
day.
Okay, and just doctor, just to summarize, like the second hyperbaric, it was done when he already came with another symptoms with palpitation.
Yes, there were added symptoms of chest pain and palpitation.
Palpitation, okay. And then he presented, and then he had, and this was how many days after the second visit to the ED?
First visit and second visit has a gap of 10 days. Then the third visit is after 3 days. So after the second exposure to the same car, after it returns from the garage, patient is reviewed, but he's having persistent symptoms. At that time, there is no indication for hyperbaric, so he was discharged with treatment in A&E. Then after
Oh,
3 days, when he is having persistent symptoms, he is coming back to ED with the same symptoms of dizziness, shortness of breath, headache, palpitation. He's investigated again, and all investigations are unremarkable. So we planned for hyperbaric. The session
interesting.
which was should have been done before, but the patient did not show up at that time. And he was also referred to cardiology.
Excellent, very interesting case. Dr. Suad, would you like to give us your comment?
Yes, so basically just to insist on few things. When they do the hyperbaric, just for the audience, they have the hyperbaric therapy comes in sessions. Sometimes they do 3 according to the severity. Mostly it's 3 sessions of hyperbaric oxygen therapy within 24 hours or more. That will be decided upon the hyperbaric, specialist. and according to the system. So the agreement between us and the hyperbaric therapy is that he go for considered as significant symptoms. So he have done one, and then he was decided for a second one next morning. The patient felt like he's better, and then he did not go for the second hyperbaric oxygen therapy. What I want to insist on in this, pathophysiologically, when you have a high CO level will, the initial mechanism of action is just displacement of the oxygen from the hemoglobin. It has a high affinity to hemoglobin, which is 200 times higher than the oxygen. The second mechanism is it's related to cellular damage. It's cytochrome C oxidase inhibitor. So it affects your mitochondria and affects the cellular level. Third thing, it has an effect on the lipid peroxidation. That's why we have the CNS symptoms. So there are multiple mechanisms of action for the carbon monoxide poisoning. And the other thing is that it's not always that the blood level correlate well with the symptoms. You might have a normal CO level, but a high tissue level of carbon monoxide. So it's not always correlated with the symptoms. So sometimes we may go for the symptoms, and by that time, the patient has cleared by the normal oxygen has cleared from and the blood level might be normal, but the tissue level might be high. So this is the other thing. So the second encounter was was symptoms mostly of cardiovascular symptoms like palpitation, sweating, shortness of breath, with a T-wave inversion in the inferior leads, but the troponin was negative. So is there any cardiac effect of carbon monoxide? Yes, carbon monoxide may affect it has a high affinity as well to myoglobulin, and it affects the cellular respiration, the myocardial cells, and then it may lead to ischemia, might lead to arrhythmia, may lead to it. So it's known for CO poisoning to cause some sort of cardiotoxicity, and the workup may from troponin to echo to Holter according to the severity of the case. So that's why the patient was referred to cardiology eventually. But then, we thought of, since he has that T-wave inversion and, again, a third presentation, maybe he did not clear the whole carbon monoxide with multiple exposure. So that's why we insisted on a second session of hyperbaric oxygen therapy, although this was not as clear indication as how it's listed in the clear indication, but it's reported in some literature. You may go for hyperbaric therapy with multiple exposure, normal level, and then some cardiac symptoms.
Excellent, دكتورة سعاد. دكتورة Sami, do you want to add anything?
Yes, thank you. Thank you so much. Hello, everyone. Thank you, Dr. Afra, for all your effort to maintain the Menatox clinical rounds and for all your effort for the cases. Thank you so much, Dr. Suad and Dr. Hala, for joining this session. Actually, I would like how to say it, felicitate you about this great efforts regarding this CO. It's not straightforward, actually, this case. The thing that I want to, this is having many learning items or learning thing, starting from the point that it was not clear as CO regarding the history, how it is important to get the history regarding the fresh air sign when the patient improved when they left the car and worsened when they returned. This is all important for the CO. The differentials also were difficult. So regarding the for example, for a physician in the ED in the busy ER, having the SpO2 97% without thinking about HbCO or sending for carboxy hemoglobin would miss such a case. This is really important. Regarding the hyperbaric oxygen, actually having the loss of consciousness and the repeated attempt, or the repeated exposures would be like given this decision as a good one to give this patient, because for here it's crucial to prevent the delayed neurological sequelae. The other point that I wanted to mention is regarding the I agree regarding the cardiotoxicity, because CO will bind directly to the cardiac myoglobin with even higher affinity than hemoglobin, and this will cause direct mitochondrial dysfunction in the heart. Even with normal coronary arteries, these patients can have angina, have EKG changes. This is all a marker of severity. So mainly for these patients who would need not only to treat the patient but also to treat the environment. So what we need to is to do not get back to that car, to that house for other cases until the prevention are made. Also, the second thing is the follow-up. It's really important, because this patient, he improved after the third encounter, but likely he will, have, he needs the neuropsychological screening in 4 to 6 weeks after. This is really important for him. So this is mainly like a learning for, case for all of us regarding these cases. Especially when we think about drivers or even in the household. Thank you.
Thank you so much, Dr. Samia. I just want to add one thing. When it comes to the delayed neurological sequela, usually it's not the symptoms that the patient has on presentation. So usually what happens usually it starts within 2 days from the exposure up to 40 days from the exposure. So yes, I agree with you. This patient will need follow up. I just question for Dr. Suad. Did this patient he was followed up, in the clinic or even by phone, to assess his symptoms?
Luckily, actually, the patient is a paramedic, and he's with us in the webinar, by the way. So if you have any question, just post it in the chat. He's Mr. Aziz, and he's with us in the chat. In the webinar. So he's a friend, and we're continuously doing a phone follow up as part of the toxicology service follow up. We're following him up. Luckily, since that time until now, which has been more than 6 weeks, he is free of symptoms.
Excellent. That's really excellent. We are happy for that.
So if you have any question for him and how did he felt, you can just post your questions in the chat.
Excellent. Okay, so Mr. Aziz, just make sure that your messages are directed to everyone. So, Dr. Maha, we can go ahead. I think it was really, handled very well with the discussion. So we're gonna pause here and just to keep up on time, and we will move to our next presenter. Thank you so much, Dr. Maha. Thank you for your presentation. Excellent case and excellent catch, honestly.
Thank you so much, Akira, for the chance to present in this grant organization.
Oh, thank you. I'm happy to have presenters. Actually, I'm always looking for presenters. For those who are interested, even to present for the next upcoming webinar, please feel free. To send me your cases. I will just a few minutes. I will just share my my email. Just to keep up on time, we'll go to our next presenter. Our next presenter is Dr. Hala. Dr. Halia, she is a senior emergency medicine doctor at Muscat City for military and security service. She's a full member of the Royal College of Emergency Medicine, and she has finished her training in Sudan Medical Specialization Board. So welcome, Dr. Hala.
Hello, everyone, and thank you for having me, Dr. Afra and Dr. Saad, and all the rest.
Sure, it is our honor. Can you see my screen?
Yes, I can see it.
Excellent. You can start.
Yes, I will start my presentation. The title will be When the Gaps Matter, as you can see. Can we move to the next?
Yes.
So the chief complaint of my patient, he is a male, 48 years old, presented with headache, dizziness, vomiting, and abdominal pain. There's suspicion of a history of a syncope, but it unwitnessed. And when the patient arrived to the ED, he was completely fine. The duration of symptoms is unknown because the patient was a little bit confused. We go to the next. For the analysis of the chief complaint, and patient had the headache, was severe for unknown time. It was all over the head, associated with nausea, dizziness, and the dizziness is aggravated when the patient tried to stand. And he had a vomiting. It was large amount, green, and he had some mild epigastric pain and mild diarrhea, as he said. The past medical history of the patient, he is a non-alcoholic patient, but as he mentioned, he stopped alcohol few months back. He is a chronic smoker. He is a known case of irritable bowel syndrome. He has high lipids. He has been recently investigated for the recurrent attack of syncope by doing an MRI by neurologist, which came back negative. Next. On physical examination, the patient looked very emaciated. He was very dehydrated and he was agitated to sit on the bed, and he had associated tremors on his hands. Vitals initially was all within normal. With neurological examination, only the patient was only confused. He had ataxia when trying to walk and steady gait. By examination of the eyes are fine, pupils reactive normally, no nystagmus, but he has a rhombic sign positive. Respiratory system, cardiology, and GI system, musculoskeletal system was all within normal limits. And we can go to the next slide.
Okay. So just before we go to the investigation, just give us a summary about the case. So this is like an altered mental. You can just give us a summary about the case.
Yes, we have a 48-year-old man who presented with signs and symptoms of headache, altered mental state, confusion, and some abdominal pain and vomiting. And the duration is unknown. He is a non-alcoholic, but now, as he said, stopped alcohol. Other systems were fine. Examination, he has some ataxia and some confusion. He was dehydrated and emaciated. This is the
Excellent. So doctor, just a question. When you said that GCS was 14 for this patient, so what do you mean? Like I mean, he was able to obey command or not?
No, the patient was confused initially. When he
Initially.
presented, he was confused, yes.
Okay. Okay.
But the other examination, like the motor sensory, was fine. The patient was actually very agitated. Even the cannula cannot be like to be put at the start. But after that, the patient calmed down and still confused, or he had like some labile consciousness.
So I am assuming the GCS was lower than 14 then. If he was to that extent confused that IV cannula was not be able like to be inserted, you know?
Because of the agitation.
Yes, because of the agitation.
Yeah.
Yes. Oh, okay. So we can go next to
Investigations.
yes, for the
So
VBG.
investigation bedside was looking for the glucose, which was 15.5. The ABCD approach of the patient was fine. We want to do the VBG for the patient, which showed the pH of 7.15, CO2 of 13, HCO3 of 11, sodium 142, potassium of 5.9, chloride 88, lactate 3.6. ECG was done also bedside. It was normal.
Okay, I just will pause you here. So I'm
Okay.
going to open the discussion, and before opening discussion, I just want our participant, I mean, to tell us what do you think about this case? What is your differential diagnosis for this patient? Middle-aged patient coming with confusion, altered mental status, I would say with GI symptoms, and I mean, I would say this is like this is a CNS symptoms, and there's a GI symptoms. So before we go to the labs, I mean, I want your differential diagnosis. So even like ordering labs should be based on your differential diagnosis. Okay, excellent. There is alcohol withdrawal. For me, I would really highly think this is an alcohol withdrawal case. I agree. CNS infection, excellent. So I would think about that. Could this be encephalitis or meningitis? Excellent. Alcohol poisoning. Okay, so it could be as well. Although like we need further investigation, like ethanol level, all of that. Yes, because it could be just alcohol intoxication. But I'm assuming like with the presentation, they will be like you will smell the alcohol as well, so it can direct you to the different your diagnosis. So vitally, according to my understanding, vitally he was stable, right, Doctora?
Yes, he was stable vitally,
Like within normal limits.
within normal limits.
Okay, good. Alcohol poisoning, alcohol withdrawal. So we have his hypotension, tachycardic, febrile. No, he wasn't. Most of his vitals within normal level. High anion gap with okay, patient stopped alcohol since patient stopped alcohol since 5 months.
Yes.
Yeah, which it is a significant, I mean, a long time. However, we all know that when we are in the emergency, I mean, department, and we are dealing with patient with alcohol issues or alcohol use disorder, always the alcohol history is not accurate. We know that, that always because of I mean, for the stigma and for all of that, patients are not very, يعني, honest, I would say, when it comes to their habits of alcohol drinking. And so that's if the patient is known to have to consume alcohol, then I wouldn't really rely on that history that he stopped alcohol 5 months back. How can we suggest okay, withdrawal? Yeah, it could be as well. So Dr. Suad or Dr. Samia, do you want to add anything? Excellent. Who said alcohol hepatitis? So if you think about, I mean, hepatitis with, let's say, ammonia, it could be ammonia encephalopathy, yes.
Yeah,
Or
let's say about sepsis as well. Severe sepsis.
severe
Totally agree actually with the list of differential. Common is common. So what we will think at that time is the same as everyone thought, like common is common, could it be sepsis, CNS infection, alcohol intoxication. These patients who are يعني especially like the heavy and the frequently presenting alcohol consumers, they will deny, every time you ask them, they will say, no, we didn't drink for a month. And
Yeah,
then you're
maybe.
not sure about that. So history maybe is not reliable. And then you use your other. The other thing, anyone thought of calculating the anion gap in this case? Like whenever we have alcoholic patient and then AKA
Yeah.
alcoholic
Diabetic.
ketoacidosis.
Maybe diabetic ketoacidosis. Yeah, if we don't
So
know.
I don't know if anyone has calculated the anion gap. We would like to hear that in the chat, or maybe Dr. Hale may proceed to tell us further.
Yes. Okay, we can proceed, and then I mean we'll pause again for a further discussion. So, Dr. Hala?
Yes. Continuation of the investigation, the patient had an anion gap of 48.9. And patient had the serum osmolarity of 332, which is very high. And also the osmolar gap calculated was 40. Urea was 8.2, creatinine 146, which acute kidney injury. Hemoglobin was 13, which is fine. Platelet 107. WBCs was 4.9. He had AST of 105, ALT of 68, some sort of transaminitis. Brain CT was done from the ED, also was negative.
Excellent. So, okay.
This is when we like calculation for the when to calculate the osmolar gap. We have the measured osmolarity and the calculated osmolality. So we have the measured was 332. The calculated, we use this equation, which is 2 times the sodium plus glucose divided by 18 plus BUN divided by 2.8. And when we like got the the value, it was, as I said before, it
Was
was 40.
48.
The osmolar gap, yes, osmolar gap was 40.
Yes. So just like here, just to pause for a minute. What is now your differential for high
Now
osmolar?
we have a differential for high anion gap, severe metabolic acidosis, and differential diagnosis of high anion gap with high osmolar gap. And
yes.
what can cause us severe
Yeah.
metabolic acidosis that associated with two gaps, the anion gap and the osmolar gap. That is very, very high.
So just share your thoughts about it.
Regarding my thought, we have alcoholic ketoacidosis from the start, but it wasn't the case because the patient wasn't diabetic, and because the osmolar gap was very high, we thought there is some osmosis in the gap, like there is something the patient ingested, some acid from outside.
Yes,
So
I agree. But Doctor, just can we pause for the audience to share their thoughts as well? For the audience, share your thought. What would be your differential? So here there's a severe metabolic acidosis with high anion gap and high osmolar gap, and in the same times you have renal impairment, AKI. So we have methanol. Good. What else other than methanol? Okay, we have ethylene glycol. Good. Methanol, ethylene glycol poisoning. Okay, I would say these are the two most common toxic alcohol that usually, available or people have access to it. Okay, so we can go ahead, Doctora. So what
So,
happened?
course from A&E, it was, as I said, ABC approach was the glucose, ECG, hydration started because of the vomiting. PPI has been given, brain imaging has been done, antiemetic, thiamine, because we didn't know is it a withdrawal or intoxication. And when we got the VBG, we consulted our toxicologist, Dr. Saad Suleimani. She recommended to stress on the possibility of taking any alcohol. And if there is any visual symptoms, with the patient completely denied at first.
Okay,
So
which
we
usually
get
happen.
the hydration and continue with the symptomatic treatment. Even diazepam has been given for the patient because he was very agitated. And we got the next VBG, anion gap is still very high, it was 38. And the toxicologist has been called again regarding that the anion gap is still very high, patient no improvement in the symptoms. She recommended to still ask the patient again and refer to medical team the patient, because with these figures, he needs to be like managed, even if we don't have the diagnosis now.
I agree.
And can move to the next slide. When the medical team came and saw the patient, at that time the patient admitted that he took some sort of like homemade alcohol.
Homemade alcohol.
And,
Excellent.
yes.
So I'm gonna pause you, Doctora, now just to open the floor for Doctora Suad.
Yes, thank you, Hala, for the presentation. So, first of thing, this is a case of toxic alcohol. I want the audience to differentiate between toxic alcohol and alcohol intoxication, totally different things. So, alcohol intoxication is because of the ethanol that's consumed, the normal alcohol. Toxic alcohol are different alcohols, which are three main types. There are a number of them, but the three main toxic alcohol are methanol, ethylene glycol, and isopropyl alcohol. These what we call as toxic alcohol. They have different sources. And in this case, the source basically was homemade alcohol, in which we have outbreaks in some countries. You may have individual cases as a source of toxic alcohol. The other source, which is ethylene glycol, might be from the antifreeze fluid, from the car cooler fluid, in which it may be used, or suicidal ingestion of that fluid may lead to toxic alcohol. The other source is isopropyl alcohol, less toxic, which is from the wrapping alcohol. So these are the three toxic alcohol. Basically, the problem is not from the initial compound. The problem is from the metabolites. which are the acids. So all of the metabolic pathway of all of these toxic alcohol will lead to a formation of a toxic acids. And in case of methanol poisoning, you may get, it's a very difficult, to be honest, like a toxic alcohol without a clinical clues might be difficult. Here, the clinical clues that we were looking for is a history first. So he denies initially the history that we were insisting to ask 1, 2, and 3 times. And you know, these patients, sometimes they will deny what they took. So there was no clue from the history. Then the eye symptoms, because methanol will be metabolized into formic acid, and that, you know, formic acid will be is affecting the optic nerve, causing blindness and storm visual disturbance. So these two clues initially were missed, but we had a biochemical clue of having a very high anion gap. So initially we said, okay, this high anion gap metabolic acidosis may have other causes. So that's why we didn't start the treatment initially, because there was no clinical clues, but high anion gap, which is really high, 40. So what's contributing to that high anion gap? Then we started to look for other differential diagnoses, but we couldn't find any. So he was not septic. The patient did not have any GI bleed. He did not have anything that will lead to clinically, that at least will lead to high anion gap. Then we said, okay, it's a high anion gap, no clinical clues, but let us check the serum osmolality. We checked the serum osmolality and we calculated the osmolar gap. Osmolar gap came 40, which is very high, you know, osmolar gap. Although we didn't calculate the ethanol with the osmolar gap, but with all those those biochemical clues, and later on insisting on the history, then he started as headache, and then he said, yes, I have visual disturbance, in which he denies initially. All of that led into, you know, the diagnosis of methanol intoxication. So later on, everything became clear. He said, yes, I took sort of alcohol, which is a homemade alcohol. And then he said, yes, I have visual symptoms. And then we had the evidence of high anion gap, high osmolar gap. So this is clearly like as a toxic alcohol, methanol intoxication.
Excellent, Dr. Suad. Dr. Sami, do you want to add anything before we proceed?
Yes. So this is so for this case mainly, the first thing that I wanted to add is about the anion gap and osmolar gap. So just I wanted to mention that here we had it high, but if the patient comes late, we will have the anion gap high, but the osmolar gap will be less, because osmolar gap is due to the parent molecule, which is one of toxic alcohols, but the anion gap is related to the metabolites, the byproduct. So that's why we should not focus on the osmolar gap. Even if it's not high, we need to consider these toxic alcohols, because we are not having like the cases all early on. Some cases are delayed. So the double gap here presentation is like typical to such exposures. The second thing I wanted to mention is about lactate. So lactate mainly, if we have it high, it's due to, if we have methanol poisoning, for example, the toxic metabolite would be the formate. The formate is mitochondrial toxin, which inhibits the cytochrome C oxidase, and which will force cells into anaerobic metabolism, and we will have the lactate or type B lactic acidosis. However, if we have ethylene glycol, mainly we will have lactate higher, and it would be falsely higher due to glycolate, which is metabolite of the ethylene glycol, which is like having the false higher tests in the POCT. The third thing that I wanted to mention is about this patient. This patient claimed to have stopped drinking. This is common behavior pattern in toxic alcohol ingestions. Mainly, these patients often consume the rubbing alcohol, homemade distillates, or windshield fluids, because they are trying to avoid regular alcohol, or they cannot afford it, for example, and they will mention that they stopped all of this. This is mainly what we can find. Yeah, this is mainly what I wanted to add regarding now. Only the latest point is regarding the tremor and agitation. So this is a question, general question for the audience or for Dr. Suad or Dr. Hala regarding this patient. Like, did we consider if there was a component of ethanol withdrawal superimposed on the methanol toxicity, or was this agitation purely due to the effect, or we have like co-adjustant?
Actually, that was considered initially with the initial presentation as initially like withdrawal because the symptoms directed toward withdrawal rather than intoxication. But later on with the biochemical markers, no, we deviated into like thinking of toxic alcohol. And sometimes like these patients who are regular in alcohol, they know themselves. So sometimes they take homemade alcohol, they started to be symptomatic and they take the ethanol, the alcohol, the normal alcohol, the expensive alcohol, like not the cheap one. So they treat themselves. So this may happen sometimes, like with the patients. So yes, that was considered initially, but later on, no, we made it lower as alcohol withdrawal, and we went high with the differential as toxic alcohol.
Excellent.
Thank you.
Thank you for both Dr. Suad and Dr. Samia. Dr. Hala, we can continue just to keep up on time.
Okay. So, regarding the management, the patient has been seen by the medical team and he was planned for ICU admission. For dialysis, because we didn't have the antidote in our facility for mebizole, and the patient like referred to the ICU, and when like they're about to start the dialysis, we have the antidote from another facility, and he was admitted for observation for any possibility of like seizures, management of the agitation. Fomepizole has been given initially 15 milligram per kg as a loading or a bolus first, and then he has been given 10 milligram every 12 hours for a total of 48 hours. The patient didn't need any dialysis. He continued on hydration and the kidneys started to recover. And after that, the sequel of the patient, his symptom improved over 3 days, and then he was like downgraded to the ward. Has been assessed by symptoms dramatically improved, assessed by the hepatology, ophthalmology, and GI doctors, and discharged home with a good condition.
Excellent. How many days he stayed in the hospital, Doctora?
3 days.
3 days. Excellent,
Yes.
actually. Yes. And he received also dialysis during these 3 days.
No dialysis. All Fomepizole and hydration, and he was fine.
Okay, that's excellent.
Yes.
Here a question. If consuming high percentage alcohol drink like 70 proof, does it cause alcohol toxicity or still intoxication? So this is not, I would say, a question related to the case itself, but to answer a question, when we say 70% proof, what does it mean by saying 70% proof? It means that the alcohol, it does not contain 70%, it contained half of that. So what is the half of 70? Is 35% of alcohol. And basically, if we think about it, many of, like, for example, I would say, I mean, some of the wine may go to up to above 20%, 20% of alcohol. But let's say vodka, whiskey, all of this actually contain even up to 40% of alcohol. So if you will convert that 40% to alcohol to proof percentage, it will be almost 80, because it is the double, or you divide, يعني either one. So I would say why, I mean, it depends on the amount the patient ingested, and there's multi-factor to cause alcohol intoxication, especially like, I mean, is the patient naive or alcoholic? Is the patient consume a large amount on empty stomach or non-empty stomach? Then comorbidities also, I mean, contribute to this. So many factors contribute to, I mean, alcohol intoxication or not. So if that, I hope that answer your question. So I wouldn't say like 70% proof is a high concentration, because it's basically 35% of alcohol. Yeah, it is not, I mean, it considered high, but not very high. I would say that. I mean, for this, we will, I mean, try to wrap up our case. So just, I would like to thank Dr. Hala. Thank you so much for this great case. Very interesting case, and I would say it's challenging. And before just we conclude our case, I would like just to ask Dr. Samia and Dr. Suad if you want to add anything.
Just one thing to add, I think the limitation of investigation and the limitation of the antidote regarding toxic alcohol is everywhere around the region, and we face all of that. We are discussing that every time in our conferences, so it's very important to concentrate on the clinical clues and, whatever investigation that will be available, which are the BBG and the osmolar gap, to direct you to the diagnosis of toxic alcohol. In most of our facilities, like toxic alcohol panel is not immediately available in all labs. It needs to be sent to a central lab. It takes time. By that time, the patient is very symptomatic. So please depend on the clinical symptoms rather than whatever investigation you have, rather than depending on methanol level or ethanol. That may guide the treatment later on.
Excellent, Dr. Suad. Very excellent advice. I would say that you should never delay the treatment for toxic alcohol if you even suspect it. So still you can start the dialysis, you can start fomepizole if it's available, but never delay it just waiting for confirmation laboratory, because basically in our region it takes up to a week, to receive the result. So you will just, empirically start the dialysis. Especially if the patient was having, high osmolar gap with the high onion gap and metabolic acidosis. So, it will help the patient, even if later on it turned to be that this is like another case, or not toxic alcohol. Still, dialysis will benefit the patient, I would say.
I totally agree with you, Dr. Saad and Dr. Afra, regarding this point about not waiting for the lab and treating the patient if we suspect or highly suspect toxic alcohol's exposure. The point that I wanted to add is about the fomepizole adjustment doses. If we start dialysis, make sure to adjust the fomepizole doses as it is dialysable also, as the fomepizole and dialysis are not they are treating both, but it's not the same mechanism. With fomepizole, we are preventing to have the byproducts, the toxic byproducts, and with dialysis, we are helping to eliminate the metabolite and also the parent molecule. That's why if we do the dialysis, we should also continue treatment with fomepizole, and we should adjust the doses of fomepizole to not lose the effect of fomepizole. This is all from my side. Thank you.
Thank you so much. Thank you, Dr. Suad. Thank you, Dr. Samia. Excellent discussion. And thank you for our presenter. Thank you for all attendees who attended today's webinar. Please, if you would like to, contribute to this webinar, if you would like to, join us as a presenter, just send me your cases through my email. I just shared my email. Thank you so much. And just before we end it, كل عام وانتم بخير ورمضان مبارك. In Ramadan, we're going to stop the series and we'll resume inshallah after Ramadan.
Thank you, everyone. Thank you, Dr. Afra.
Ramadan Mubarak.